this? What is the digestible material we can leave here with, understanding now we have a very early 3 months data in the slurry of other data that we have for Aquablation. Here are my disclosures. Looking back, and Dr. Ritter presented on this, sort of the walkthrough of where this came from, the initial 2017, I was part of the WATER3 trial, where we had very novice surgeons. As you can see here, 101 patients trained, treated at one of 16 centers among 24 surgeons, so low volume, first-time users, and we used no cautery. We used this thing called the CTD. No one talks about it, but this is where all this initial data that got this published and used was founded. And we looked at those first 3 months data endpoints, and you can see here we have now 5-year data, but we were lacking at that point the confidence to embark on a randomized trial that Dr. Ritter and his team did now, looking at that 5-year outcome data. And really, I think one of the questions we're going to want to answer in 5 years is here. What is that medical and surgical failure rate with experience, with better knowledge of using the cautery and resecting more tissue? Are we going to get better results? But even those, for novice non-users who are not going to go off and do a fellowship for HOLEP, can get that kind of data. I think that's quite astounding in the grand scheme of number of men we're going to have to treat in the next 10 years. So looking at the data, comparing the WATER2, chiseling away and looking at that inclusion of what we can see, very similar in terms of the prostate volume, 107, 108 cc's, middle lobe, the number of men with retention, not much different between WATER2 data and their Aquablation WATER3 data. And the only real difference you can see here is the number of grams resected. We didn't resect anything. We put a balloon in. Now we have resected 7 grams of tissue, and we use bipolar loops in that group of patients. And how'd that fare out? Look at the transfusion rates, which was once a kind of Achilles tendon, what we were hearing about for the WATER2, 5.9% transfusion rates, some takebacks, but in this series, 0. There were some takebacks, but no difference compared to the HOLEP. They didn't present their 1 month incontinence. We'll hopefully see that in their publication, but at the 3 months, when you look across the incontinence, stress incontinence, 0% for both WATER2, again, novice users, and with more experienced users. No difference in PVRs. And in terms of the ejaculatory, you would think maybe you're resecting, and I think initially what was told to us when we use bipolar, we may injure and cause more ejaculatory dysfunction. Look at that. We're actually having a bit more preservation of ejaculation for this series with bipolar. Now let's sprinkle on their other arm of expert users of HOLEP. So you can see here, the OR time, the amount of grams enucleated and resected, 74 grams, the transfusion rate, 2.3, but not significant between the Aquablation group. But the incontinence rates, again, measured as strict incontinence, 1 pad or more, 9.1% at 3 months. I'm sure that will continue to improve, but I think the honest reporting is very, very nice here. Looking across antegrade ejaculation, you can see 23% for HOLEP. No one, as expected, no one had any ejaculatory dysfunction. Busy slide here. This is just the IPSS is at baseline in blue. Orange is 1 month. In gray is the 3 month, comparing Aqua, WATER2, WATER3, and then laser enucleation. Bottom line, comparable IPSS improvements and deobstruction for these large 80 to 180 gram prostates. As we know with Aquablation, we can contour, we can plan, we can personalize the care. You can see here letter D is where we park our camera. That's where the verumontanum is. And there's a buffer that we deliberately save that tissue to minimize incontinence. It's done deliberately to preserve ejaculation. That's what we're doing. We do the butterfly cut, so understanding that we're not going to have any injury to the vero and hopefully the ducts beyond the verumontanum. And usually this is set for 1/3 the distance. And as a surgeon, you make that movement, and you're trying to preserve the ejaculatory duct. You may leave some anterior tissue, some go after it. But if you look and you study this data of the grams resected between those two cohorts in the WATER3 data, you can see there's a 51 and 76%. So we know this. I don't think anyone's going to argue. We're actually deliberately going to leave, purposefully, some apical tissue for the benefit of the patient. That's the trade-off. We know that, and I think that's the discussion we have with our patient. And you can see it here. It's done for that purpose. And if you look at compared to the WATER2, I just went back and dug that data out. We actually did a bit better. So we actually had 41% reduction in volume compared to the 51% Dr. Ritter and his team had. A little critique there, just in terms of presenting only the truss volume. At 3 months, this is typically where I'll bring out my ultrasound and show the patient their defect, but how can we accurately, there's no accurate measure of that volume of a hole within a hole. And some of the HOLEP data has told us, well, we should be using the PSA, tin-methylol direct proportion of PSA reduction, and the nadir at 3 months usually is stable there onward. So I would hope that they, I think they're going to be digging that up and looking at it, and just look at the WATER2, did it correlate? And did indeed. There's the 41% reduction we talked about, and if you calculate the PSA before and after at 3 months, 39%. So just to sort of, let's dig for that data. I think that's important in these patients. So game changer conclusions. What are we taking home from this today, guys? Looking at expert, over 200 very proficient LEP surgeons, 9 of them, and we're comparing to proficient, people who I call knobology. You know where the sequence of events are. You've gotten at least 30 cases done, and you're comparing the 3-month outcome. And what are the aquablation findings here? There's comparable efficacy. We're able to democratize any kind of volume of up to 180 cc's in 1 hour. So I think it's important for our OR time, and at least in Canadian, sure, other socialized healthcare systems, you can't go past 4 o'clock. You got to get your cases done. When you look at efficacy, are we getting as good IPSS and PVR outcomes? Seems so. And what about bleeding events? What was once a big issue, I don't think that's much of an issue anymore. And when you look at the focal cautery bladder neck, it doesn't impact the ejaculatory dysfunction, which was once kind of a no-no. But the incontinence rates, and I think that's something, I think we have to talk about and look at and critique, in terms of how can we do better. That's a trade-off that we have to have further discussions and really be honest, because sometimes the use of transient incontinence, I'm not sure is the right terminology. It could be permanent, and it has to be something that's brought up with the patient, because there is involvement and cost involved in that as well. With the ejaculatory function, if you use cautery, not impacted. So I think there's some clear value of using some image-guided, some of this technology that automates this procedure in terms of efficacy. It's a predictable procedure and reproducible outcomes, and improves access. So aside from the cost of getting it, it allows everyone in this room who has a hand, a foot, and a knob to equally be able to do something of a HOLEP-like outcome in a reasonable amount of time with the number of men that we're gonna have to be treating in the next 10 years. So moving forward, what's gonna happen next year? What am I looking forward to? This is what we're looking at. At 5 years, are we gonna do better than what we had there in terms of medical failure and surgical failure? It's gonna take some time to get there, but I think that's something, I think a value of this study, and to congratulate the authors for that. Key words here is standardization. I think we need to standardize the definition of incontinence. So I know that the Rock Group presented not too long ago, they published on their series of Aqua and HOLEP 75 men in a non-randomized fashion, equal size big prostates, again, showing at 6 months, 3% incontinence versus 0, but their definition was 2 pads or more. So having 1 or 0 pads was considered social incontinence. I'm not sure that's the standardized way of looking at it. And when I did robotic prostatectomy, if I presented, that wouldn't get published. So I think we need to be as strict and talk to our patients how many pads is a pad weight, so standardize that. And other things to look at is, what is the cost outside of the hospitalization of someone going through that continence recovery? Physiotherapy, wearing pads, diapers, involvement in sports, maybe not doing things with their wife or sexual activity. I think that needs to be calculated and maybe another subject of another study. And finally, we never talk about us. We have timeouts for our patients. We take care of our residents, but no one looks at you, the surgeon, and says, what's the cost to your body, the durability of the surgeon body and the stress levels. And I think something that we should be looking at when at the end of a day of the various BPH surgeries, is there are certain levels of stress and anxiety that we don't measure or we just kind of put on our back and accept. So with that, I thank the team for the involvement and the authors, the Ritter and all, to continue on their request for the 5-year data. Thank you.